So we move on to the next session, that is management of hyperleukocytosis. So to chair the session, I would request again Dr. Dinesh Bhurani, Director, Department of Hemato-Oncology and Bone Marrow Transplant, to chair the session, and Dr. Uma Hariharan, who is the Associate Professor, Department of Critical Care Medicine at Atal Bihari Vajpayee Institute of Medical Sciences and RML Hospital.
Very good afternoon to all of you. I know you all are waiting to have lunch, but we are going to have a very interesting session on this Oncocritical Care Conference on hyperleukocytosis by a renowned speaker, Dr. Rohan Haldar, who is a consultant in the Department of Hemato-Oncology and Bone Marrow Transplant here at Rajiv Gandhi Cancer Institute and Research Center. I really take great pride in coming here every time. This is my alma mater. I have done a few years of training here, and really nice to be with all of you, and thanks to the organizers for making me a part of this. Thank you.
Good afternoon, everyone. Am I audible? So, good afternoon, everyone. I would like to thank the organizers for having me here. So, the topic that have been allotted is management of hyperleukocytosis, and I've added leukostasis because it is one of the common complications and a difficult complication to recognize, to identify in patients with hyperleukocytosis. So, to define hyperleukocytosis is usually defined at, when a patient of leukemia presents with a TLC count of more than 100,000 per microliter. This is not a watertight definition, and some studies have used a lower cutoff, that is the TLC count where the TLC count is higher than 50,000. They have used that TLC count as a cutoff for hyperleukocytosis. But the commonly accepted definition is when the TLC count is more than 100,000 per microliter. Why is it important? Because hyperleukocytosis is an oncological emergency, and it is associated with an unfavorable outcome and high mortality of about 20% in many studies. The causes of mortality commonly being bleeding, thromboembolic events, neurologic and pulmonary complications. Now, what drives hyperleukocytosis is basically twofold. One is there is a rapid proliferation of blasts in the marrow, and there is disruption of the normal addition of the blast in the to the marrow cell niche, which leads to higher tumor burden in the peripheral blood. So we see a high total leukocyte count or a high blast count in the peripheral blood. So hyperleukocytosis can lead to three of the common complications. One, it can lead to disseminated intravascular coagulopathy. It can lead to tumor lysis syndrome, or it can lead to leukostasis, which I'll be discussing in my further slides. So, hyperleukocytosis is seen in about 5 to 20% of AMLs, commonly the M4, M5 variety or the variant type of the acute promyelocytic leukemia, AMLs with NPM1 positive mutations or with FLT3 ITD mutations, or AMLs with MLL gene rearrangements. In ALLs, specific cytogenetic subgroups like those with translocation 411, 922 translocation, that is Philadelphia positive ALLs, and those with translocation 119 present with hyperleukocytosis. TALLs deserve a special mention because they present with hyperleukocytosis, they have mediastinal masses, they have CNS involvement diagnosis, and present with massive organomegalies. Other differential diagnoses of hyperleukocytosis are CML in accelerated phase of blast crisis, and rarely you can have CLLs who are on treatment or at the time of diagnosis presenting with hyperleukocytosis. Now, leukostasis is a difficult to identify complication of hyperleukocytosis. It has two definitions. One is a clinicopathological definition. So basically, this is the clinicopathological definition is where you have morphologic evidence of blasts that are occupying whole of the vascular lumen with or without associated fibrin. So this is a cross section of the blood vessel, which is showing that this is full of blasts, and some of these blasts have managed to extravasate into the extravascular tissue as well. clinically, any patient presenting with leukemia and hyperleukocytosis, if he has any of the pulmonary, neurologic, or any other organ compromise, fits the diagnosis of hyperleukocytosis with leukostasis. Now, leukostasis is usually more common in AMLs when compared to ALLs. The reason being that the AML blasts are larger and they are less deformable when compared to ALL blasts. The further pathophysiology I'll be explaining in the next slides. Now, coming to the clinical features, this is a table showing the different clinical features of leukostasis depending on the frequency of involvement. So, as seen from the table, lung involvement is very common. So, they usually present with dyspnea, hypoxemia. They can have respiratory failure or diffuse alveolar hemorrhages. They can the leukostasis can lead to CNS involvement. They can present with confusion, dizziness, headache, coma, and focal neurological deficits. They can have retinal hemorrhages, tinnitus. They can have thrombotic complications like myocardial ischemia, limb ischemia, or priapism. So this was a very old study somewhere in 80s that was published by Novotny et al., where they tried to define because leukostasis is a very difficult to diagnose condition in any ALL or AML patient, any leukemia patient. They divided into possible, probable, or highly probable leukostasis depending on the pulmonary, neurologic, and other organ systems. This is, however, not used nowadays. Now, coming to the pathophysiology, there are two models of leukostasis. First is the rheological model. I would like to draw your attention to these two test tubes. On the left is of a patient who has AML and has a total leukocyte count of about 2 lakhs. This is on the right, we have a normal age match control. This is the centrifuge sample where we can look at this. This is the buffy coat, and this buffy coat is mainly composed of the leukocytes or the blasts. And when compared to the normal sample, it is much significantly higher. Now, it has been seen in vitro studies that when there is increase in the leukocyte, that is the concentration of the blasts are increasing, there is proportionate increase in the viscosity of the blood. So, it is suggested that when there is increase in the viscosity, this leads to leukostasis, and this is taking place most commonly in the cerebral vasculature or in the pulmonary vasculature. However, this doesn't explain the full spectrum of complications that we see. So, hence currently the cellular model is the accepted pathophysiology. So, this is a cartoon showing the cross section of a vascular lumen. These are the blasts that we see. These blasts usually secrete cytokines like TNF alpha, IL-1 beta, which leads to the expression of adhesion molecules on the vascular endothelium like ICAM, VCAM. Because of this, these blasts get adhered to the vascular endothelium, and since the number of blasts are very high, these lead to accumulation and sluggish flow of the blasts in the microvasculature. Along with this, there are secretion of matrix metalloproteinases which lead to increased permeability of the vascular endothelial cells, because of which there is extravasation of RBCs and blasts into the extravascular tissue. And all of this is happening in the tissues of the brain and the pulmonary vasculature. So this model explains both the thrombotic complications due to the sluggish blood flow, as well as the extravasation explains the bleeding symptoms, that both thrombosis and bleeding both are taking place and can take place simultaneously wherever leukostasis is taking place. Now, this is a CT scan on the left showing this is the lung window, which is showing a patient with who presented a case of AML who presented with a total leukocyte count of about 2 lakhs. This CT scan shows that in the bilateral lung field there are multiple diffuse ground glass opacities. It is very difficult to say radiologically whether this is an infection or this is due to leukostasis or because of the blast. However, in this case, it was because of the leukostasis that was taking place. On the right, this is the non-contrast CT of the brain, which shows multiple hyperdense lesions in both the hemispheres with associated cerebral edema. These are due to the bleeding symptoms that have taken place due to a patient who had hyperleukocytosis. The second complication that we see is disseminated intravascular coagulation, which is basically a consumptive coagulopathy due to excretion of tumor tissue factors and cancer procoagulants by the blast. This leads to thrombocytopenia decreased fibrinogen and prolonged PT and APTT and raised D dimers. It's usually seen in about 30 to 40% of the AMLs with hyperleukocytosis, and treatment involves basically treating the underlying cause and correcting the coagulopathy. Now, tumor lysis syndrome has already been discussed previously, but however, mainly I would like to reiterate that one has to keep a high index of suspicion and correct the electrolyte imbalances, prevented by aggressive hydration, use of uricosuric agents, use raspberry acid if needed, and if needed, dialyze the patient. Now, how do we manage hyperleukocytosis with leukostasis? First is basic principle is vigorous hydration, that is 3 liters per meter square, with careful monitoring of intake and output balance. This is to improve the intravascular volume and to improve the renal blood flow. Second thing, you prevent the the tumor lysis syndrome by use of either allopurinol or febuxostat, whichever you want to use, and use raspberry case if needed. And third principle is you reduce the circulating blast by using cytoreductive therapies like using hydroxyurea or low dose cytarabine. Eventually, you have to shift to the definitive chemotherapy, whichever intensive chemotherapy, depending on what disease it is, whether it is AML or ALL. Try to avoid any unnecessary Paxil transfusions until and unless there are any symptoms of any high output cardiac failure, because any addition of Paxils will lead to increase of viscosity, and this increase of viscosity will lead to the risk of thrombosis. Third, and the last thing is you have to correct the underlying coagulopathy by use of FFP and platelet transfusions. Our usual practice is to keep a higher platelet cutoff of more than 50,000 by use of single donor or random donor platelets. Next is cytoreductive therapy. We use hydroxyurea, that is to reduce the total leukocyte count and reduce the risk of TLS. However, there is no evidence that hydroxyurea is better than intensive chemotherapy, but in any patient who presents with hyperleukocytosis, with or without leukostasis, our practice is to start with hydroxyurea or low dose cytarabine, eventually shifting to whichever intensive chemotherapy or the definitive chemotherapy for the patient whenever he is ready. One more intervention that we usually practice sometimes is leukapheresis. Now, leukapheresis basically involves mechanical removal of the excessive leukocytes. So this process usually involves centrifugation of the blood volume, and if in any center who do not have the apheresis machines, simple bedside procedure like doing judicious phlebotomy and replacement by FFP or colloids can be done as an alternative. This results in decrease in the TLC count by about 10 to 70%. However, it is not without controversies. Now, the controversies being leukapheresis doesn't treat the underlying cause. That is, whether you remove the leukocytes now, maybe at the end of 12 hours, the total leukocyte count is going to come back to the previous value. So it is not going to treat the underlying cause, that is the rapid proliferation of blasts are not being taken care of. That is one controversy. Second thing is the beneficial effect of leukapheresis has not been shown consistently across various studies. There have been some studies that have supported its use and some studies that have not supported its use. So the result is really biased. Also, the long-term outcomes of a patient, whether he has undergone leukapheresis, whether he has that is his result on overall or relapse-free survival is unchanged by doing the procedure. The third controversy is that it has not shown to decrease the beneficial effect on preventing early death. Also, it is associated with electrolyte disturbances like hypercalcemia. It needs a central venous catheter or a dialysis catheter. You need anticoagulation. Also, it results in decrease in the platelet count, which might aggravate the coagulopathy. So these are some of the problems, and obviously cost is an issue. So what has been our practice? So usually we consider leukapheresis in any patient who presents with hyperleukocytosis and with leukostasis symptoms. If we are unable to start chemotherapy immediately, if there is suppose ongoing tumor lysis syndrome or if there is any other condition that prevents from starting chemotherapy immediately. So usually it involves about removing processing about 2 to 4 volumes of the blood volume, and usually we replace some of the blood volume by using colloids or albumin. Also, we try to avoid any blood RBC transfusions while doing the procedure, and once we have brought down the WBC count, we try to give any red cell transfusions. Usually, the leukophoresis is continued till we get a desired total leukocyte count that is less than a lakh. Cytoreductive therapy is not delayed, rather it is started immediately once we have a patient with hyperleukocytosis who presents with leukostasis. And usually the contraindications are any cardiac comorbidities or any hemodynamic instability or any worsening coagulopathy. Now, one common question is, what is the usual prognosis of a patient who presents with hyperleukocytosis? So, hyperleukocytosis is usually associated with high early mortality as shown from previous studies, and also these patients who have presented with hyperleukocytosis, they have a poorer overall and a relapse-free survival when compared to patients who do not present with hyperleukocytosis. And this is after we have adjusted for other important prognostic factors like age, performance status, cytogenetic factors, and other disease factors. But however, as of now, it is not considered important. So to summarize, so any patient of leukemia who presents with a WBC count of more than 100,000, we label him as having hyperleukocytosis. Leukostasis, the manifestations are non-specific, and any patient with hyperleukocytosis with any pulmonary, neurologic, or any other organ compromise would be labeled as having leukostasis. Management involves aggressive hydration, monitoring of urine output, treating the underlying tumor lysis, starting cytoreductive therapy, and treating the coagulopathy. Try to avoid unnecessary Paxil transfusions as it will increase the risk of viscosity and also the risk of thrombosis. And as I said, start the cytoreductive therapy and ultimately shifting to intensive or the definitive therapy early. And leukophoresis is usually reserved for patients who have presented with hyperleukocytosis and have leukostasis symptoms. Thank you.
It's very nicely presented. We have any questions for him? How will you differentiate cytosis from stasis? Is there any way we can say is only cytosis, not stasis yet? I mean,
so basically, if the patient doesn't have any other organ symptoms, just a patient walks into the OPD who doesn't have any CNS pulmonary symptoms, you would just say he has hyperleukocytosis but no symptoms of leukostasis. So any other organ involvement, like any, as I said, any neurologic or pulmonary symptoms, you would label it as most likely it is leukostasis, and these symptoms are attributed to leukostasis rather than.
This is one of the life-threatening condition. You get a recent diagnosis, and within a few days you lose the patient. So
in fact,
and
24 hours.
If you do a proper management, you can save many of them, and they can be saved from the. They can have a curable diseases also. So it's very critical early complication.
Early deaths are around 20%.
If it's managed early, can save their lives.
Really excellent talk. I thoroughly enjoyed the lecture. In your experience, have you ever treated refractory, resistant to treatment hyperleukocytosis, like which is even after leukophoresis and treatment of tumor like lysis syndrome and hydroxyurea, hydration and everything, like the entire paraphernalia of treatment given, but still we are unable to reduce the leukocyte count or maybe unable to reduce the symptoms? I mean, what is your experience and what treatment do you recommend?
It does happen once in a while. You might get a patient who doesn't respond to anything. In such cases, probably the last option is you start the definitive therapy. Usually it's with AMLs, we sometimes see, and the last option is you just start the chemotherapy, because only that will reduce the total leukocyte count and nothing else. So you have to start the.
Itself is a double-edged sword, because chemotherapy is in fact further going to increase the viscosity, the cell breakdown and other
it will increase the risk of tumor lysis, and hence it becomes
it's a very risky
difficult
situation and a dire medical emergency.
Sometimes we have patients who present with TLC count of say 3 lakhs, 4 lakhs, and we are not able to bring down the total leukocyte count. We have no other option but to start chemotherapy.
Also be prepared to start CRRT or other renal replacement therapies in these patients, because they have an extremely high risk of acute kidney injury and as well as other end organ damages.
Exactly.
Yeah.
You have to maybe sometimes start along with chemotherapy. You will induce more hemolysis, and then probably you will have to ultimately do two sessions of dialysis as well.
Thanks, Ron. With
Thank
this,
you, sir.
we close this session. Thank you.
Thank you very much.
Would request our chairpersons to kindly felicitate the speaker for the session, Dr. Burani and Dr. Uma. Dr. Rohan, please. Thank you, sir. May I now request our co-director, Medical Oncology, Dr. Lars Batra, to felicitate the chairpersons of the session.